taking part in this webinar, and we would like to express our excuses with regards to the lateness in starting. We had a few technical issues, so we had a bit of difficulties in getting our panelists connected. So, without much ado, we're going to start with this webinar. For our English-speaking audience, we'll kindly ask them to click on the button, the globe, and then you choose language, English, to be able to have the English translation of the presentation. So through this technique, you can actually listen. So for all those that speak English, this webinar is just translated. So please click on the globe and then choose the English language. Without much ado, ladies and gentlemen, good afternoon. And we are delighted to welcome you today to this webinar, which is titled Enhancing the Supply Chain for the Integration of Private Distributors in Africa. So this is organized jointly with the Pharmaceutical Distribution Association of Africa, APDA, and VillageReach NGO. To start, it is important for us to welcome you all to this webinar, and also the APDA team, started with President Mr. Larsen Sinaji, welcomes you all. And I would like to add that the VillageReach team also welcomes you to this webinar. First of all, this webinar is under a good framework of public-private partnerships, taking into consideration the health situations actually in Africa. We actually facing major challenges like the recent withdrawal of the USAID program and also PEPFAR programs by the United States. In the face of all of these challenges, we are all called to reconsider our health policies and our pharmaceutical distribution practices. One of the major points to consider is public-private partnerships and pharmaceutical distribution. Unfortunately, this webinar is of 1 hour and can only talk about the issue of integration of private distributors when it comes to the value chain in the public sector, because the area of public-private partnerships, PPP, when it comes to pharmaceutical distribution is really vast, and we would need several weeks to actually discuss it exhaustively. But today, we are going to focus on the integration of private distributors and the conclusions of our studies. This webinar is a follow-up of a comparative study from 10 countries in Africa between 2023 and 2024. And this study was actually taken by 4 Anglophone countries, 5 Francophone countries, and 1 Portuguese-speaking country. So this webinar would have 4 phases. Phase 1 would be introduction with our experts here present. Second phase, with regards to the presentation of the results of our study and also the conclusions of this study. And then the third phase, which would be with regards to advocacy. And in conclusion, we're going to have a question and answer response, which would help interaction between the panelists and the audience. This webinar would actually be moderated by experts. We have Dr. Prashant Yadav here with us, who is a global expert when it comes to global supply chain in the area of health. He is a major researcher. He has written several books on when it comes to supply chain in the pharmaceutical sector. Good afternoon, Mr. Prashant Yadav. And after that, we have Dr. Mahombisa, specialist in the private sector within the VillageReach NGO DRC. He will present the study and the conclusions. Good afternoon, Dr. Martin. And finally, we have Dr. Jules Kébé, Vice President of APDA, and is in charge of the membership and mutual aid department and is the director of DUOPHARM. He has several times collaborated with Senegalese authorities in terms of public-private partnerships. Good afternoon, Dr. Kébé. We thank all these experts for their participation in this webinar. We will be together up until 3 GMT, 3 p.m. GMT. If you have any questions, please type them into the chat so that we can actually ask them during the question and answer session. And now I would like to remind all of our English speaking audience that please click on the globe and select English language in order to actually follow the entire presentation in English. So without much ado, we're going to start this webinar, and I thank you for the time. I'll give the floor to Dr. Prashant for the introductory phase. Thank you, Dr. Prashant. The floor is yours, sir.
Thank you, and welcome to everybody. Like Dr. Nagesan mentioned, my name is Prashant Yadav. I'm a supply chain academic. I currently work at the Council on Foreign Relations. It is an important agenda item for all of us to think about. The current changes and big ticket change in global health architecture, financing for procurement and distribution of medicines does make us ask this question with some more rigor and some more urgency than we may have asked and addressed this in the past. I want to start by highlighting that private distributors are an integral part of the healthcare supply chain in every country in the world, whether it's a high-income country, a middle-income country, a low-income country. So across the spectrum of development and income profiles of countries, private distributors play a key role. If you look at health systems in OECD countries, the club of the countries which are considered to be more industrialized or higher income, we see that private distributors are the mainstream channel through which medicines and health products get from the manufacturer to the patient or from the manufacturer to the pharmacy, a clinic, or a hospital. That market is very mature and developed. There are large distributors, well-capitalized companies which have very high reach. They reach hundreds or thousands of pharmacies and hospitals. Sometimes they deliver to those locations multiple times a day, 2 or 3 deliveries per day to a hospital, to a clinic, to a retail pharmacy. So that's the structure of the system and the role of private distributors in high income, sort of more industrialized health systems. Then we see what we call as low and middle income country health systems, where there are 2 or 3 possible roles for private distributors. The first one is, we know that in many cases, the pharmaceutical companies do not have an in-country subsidiary. They do not have a legal entity in the country. And private distributors, in their capacity as importing agents and distributors, represent the companies on public tenders. So when the government is putting out a procurement tender and the company does not have a legal entity, it is oftentimes their importing agent, the distributor who has the license to distribute their product, that bids on those procurement tenders, then supplies the products, acts as the intermediary between the manufacturer and the government, and makes that channel to work. So that's one role, and I think it is important to keep that in mind, because oftentimes we assume that private distributors mean the ones that supply to pharmacies in urban, more affluent areas, capital cities only. So private distributors firstly have a role to play in what is supplied on public procurement tenders in many countries. The second important part is, in many cases, there is decentralized purchasing that happens in the public sector. So hospitals in particular, but also some clinics, purchase directly from wholesalers and distributors. And that happens because hospitals oftentimes have a formulary or a list of medicines that is larger than what the central supply agency in a country has in stock. So the hospital then says, if I have to buy something that's not available from my public sector supply agency, then I will go out and purchase this from private wholesalers and distributors. So that's the second part, decentralized purchasing that happens mostly at hospitals, but also in many cases at primary health centers and clinics, when they realize that the channel of supplying medicines that comes from the government-owned supply agency isn't working right. They use private wholesalers and distributors as a means of distributing. And a third is, we know that while the public sector distribution system caters to serving large portions of the population, there is still a significant portion of patients who access medicines in private pharmacies, in private drug shops, and the main source of supplying the private pharmacies and drug shops are private wholesalers and distributors. So again, three distinct roles. So we have to remember each of them because each of them is equally important when we think about the role of private distributors. Then we have to ask the question, why are private distributors not involved in the supply chain in many countries in a more mainstream manner? Why are they largely a marginal player? Why don't we see bigger presence? And I think it is important in that respect, before we look at this very interesting project and this initiative in the DRC, to ask the question, why do people not have a more embedded structure for private distributors? So one is an assumption that is made by public sector agency, by government leadership in some cases, that private distributors are largely in the capital cities. They don't serve rural areas. Their coverage is limited to affluent parts of the country and not to the poor or the more rural and remote areas of the country, right? So before progressing further, we need to debunk that myth that private distributors are only present in urban and affluent areas. There is some merit to this argument, but I think if you look deeply, you realize that private distributors are actually, their coverage extends into many, many parts of the country. So that's the first. The second reason why we don't see as much embeddedness is people say, oh, private distributors charge huge markups. And because of that, they take profit from the supply chain. That, once again, is not always true. And we've got to make sure that we bring out sufficient evidence to show that that is not the case. A third argument is private distributors have products of questionable quality. That is once again not true. Private distributors are regulated by the local regulatory agency in as much as stringent manner as the public sector agencies are. And we've got to ensure that if there are shortfalls in this, then the enforcement capacity of the regulatory agency, not for just approving what product is registered in the country, but for distributing products, for the practice of pharmacy and for adhering to good distribution practices, there is enforcement capacity in the regulatory agency, which then builds confidence in the payers, in the financiers, in the Ministry of Health, and in other, in many cases, external partners to say, yes, private distributors are a good channel to supply. So I think those three things, which are oftentimes the reason for why people critique private distributors, we've got to make sure we generate sufficient evidence and build the confidence in private distributors amongst the stakeholders that are involved in selecting what the architecture in a country would look like. I remain excited about what I've learned about the project in the DRC. I think also people oftentimes say that the private distribution and wholesaling market is very fragmented. There are multiple subscale, very small distributors, and therefore it becomes harder to have an engagement model with such a fragmented market. So I'm excited about APDA and the work they are doing in bringing together smaller and larger distributors under a common platform. That platform then provides us a basis to say, how can we put in place things that we want to do with private distributors, such as how do we ensure better flow of working capital? How do we make sure that invoices get paid in time, whether it is from private retail pharmacies or the government clinics or public procurement entities? Can private wholesalers and distributors extend more credit to retail pharmacies so that they can stock the right kinds of products? And also a new wave of new kinds of distribution players have started coming into the market. These are new types of distributors. They think of themselves as technology first versus technology as an afterthought. They build their distribution platforms around technology. Many of them have started Pan-African operations now, even though they may have started in one country initially. Their scale is growing. There are many examples. I won't go into a list. So we also want to make sure that the way we think about private distributors is not just what we call as conventional distributors, but also create the space in the policy apparatus for these new technology-led distributors that have come to the market. With that, I pass it back to Dr. Arnold.
Thank you, Dr. Prashant, for your introduction of this webinar. You actually gave a general overview. Without much ado, I will now give the floor to Dr. Kébé in order to follow up with the introductory phase. Dr. Kébé, the floor is yours, sir. Thank you, Arnold. I would like to greet everybody and thank you all for the time dedicated to this webinar. I'd also like to thank Dr. Prashant for his wonderful intervention. And Martin, who has been with us for quite a while now, talking about a very important topic of public-private partnerships, PPPs, with regards to the link between the public and the private entities when it comes to supply chain of medicines in Africa. So, Arnold, if you can actually share my presentation, that would be good. Hello? You can please share your presentation, Dr. Kébé. Do you have a document to project it? Yes, just to save us time, please. Arnold, the presentation is shared on the screen. Can you see it? No, I do not see it. Can the others see it? Yes, we can see it. Can you see the presentation, please? Okay, it's okay. So we will try to brush through quickly. So we will start with the context and then we'll talk about some definitions and notions and also finish with some bibliography. So APD, just to remind us about the principles of the association, which is a partner when it comes to distribution and aspires to do advocacy with the big entities on the continent. So we actually have training and information for the different members, but also partnership, especially for the topic that brings us together today, public-private partnerships when it comes to the missions we have in the area of public health. So the context can be summarized as such. More than an industry, pharmaceutical companies are going to be invested by the state with the goal of having public health at heart. So it is a partner when it comes to public health policy. So this is a quote from Kramen Gibler for the Higher Council of Public Health in France. So I introduce my presentation with this slide, allowing us to see where we are today with regards to the post-COVID-19 world, which has fundamentally changed the world, but especially in our sector with the 2019 crisis. So we have the distributors. So there's an impact that is more important, and all the different principles were questioned. And so, of course, we can actually have a trust impact with regards to consequences. So all the countries launched a sovereignty concept, and this would need to be supported by the different systems, especially we've had several alerts in Africa, especially with regards to crisis preparedness, which has actually pushed us to question our logistics, especially in the pharmaceutical sector. And this has led to structural transformations, allowing us to diversify, to have acceleration and transformation of the medicines, National Medicines Authority to agencies with authorities that are larger, especially regards to the availability and also local production. So today, the state is a lot more open to have a vision, which would see a lot more capitalistic with regards to the benefits of its populations. In the international development agenda, for us in the private sector, we should be open and with regards to this issue of public health, when I take this question of sub-Saharan countries, notably, the, they have different zones of insufficiency, especially when it comes to intervention zones of public-private partnerships, so access to healthcare, availability of essential medicines, and also neglected diseases. So if you actually try to compare this to WHO statistics, we have about 80% for 20% actually depend on the public for medical needs. So Um, so Dr. Prashant mentioned this recently, access to medicines, essential medicines for it costs about 2 billion. This can actually get to easily 50%. And especially we realize that only 20% of the world's population have access to 80% of the medicines in the world. It means that uh, and the huge mass in southern countries have difficulties in having access to some medicines, and by extension, the research budget are very, very, very low when it comes to diseases that actually strike much in on the continent, especially like tuberculosis and also diarrheas and also other diseases that cause up to 18% of deaths on the continent. So we can take a look at this slide that illustrates even in when it comes to health systems, you can have difficulties to have access to essential medicines, even within health structures or institutions like hospitals. So the solution through 3PP is a way of actually attacking public health issues. And we know that the contribution of each actor would actually be based on the actors or stakeholders' competence or skill set. So here you have some definitions of the public-private partnerships. So we have the financing model. So why do I explain all these elements? Because the actor that I am within the pharmaceutical sector is just to help us understand that public-private partnership is not just a commercial relationship. It goes beyond commerce. It actually goes with regards to provision of public services and also long-term services, and but equally a mission of actually impact. And so this impact is the improvement of the health of the populations. So there should be a proper understanding of public-private partnerships. Of course, we have the Sustainable Development Goals, and so we have the health indicators. So actually improve average life expectancy, and also the targets are shared across several countries in Africa, amongst which we have maternal mortality, neonatal mortality, the prevalence of different diseases like tuberculosis, and also another disease, and also mortality linked to non-communicable diseases. So these indicators do actually draw on a lot of interest from the public sector, because especially in the francophone countries, because they have the problems. The system in the public sector having two parallel sectors, having a private and a public system parallelly functioning. In Senegal, there were actually review of the text or the laws. So to define public-private partnerships of true that in Africa PPPs are actually linked to infrastructure for issues of economics and also or access. So like energy, roads, amongst other sectors. But in francophone countries, the PPPs are just started recently compared to anglophone countries where it's a lot more developed. And especially for health, it's just starting. And with regards to pharmaceutical distribution, it is even newer to the sector. So was speaking about the major challenges. So Dr. Um, Prashant spoke about it. So the major challenges is that we actually hope that actually the out-of-pocket payments be reduced and that this be covered by health insurance systems. And so we are talking about catastrophic or negatively impacting household spendings out of the pocket, and also the protecting the resources of also corporate social responsibilities and in terms of public-private partnerships, and also the reinforcing of the resources and what can be done in these sectors to reduce the impact on households. So for the results and action points, so we can find some points. So we talked about resources comes to enhancing public-private partnerships and also developing strategic purchasing or supply. And so with these actions and also the strengthening of the availability, enhancing the availability of medicines, especially in terms of quality medicines across all the different spheres of the health system. So the distribution network in Senegal, we have two networks. On the left, we have the private sector. So 95% of medicines are imported. With the we have four wholesalers from the private sector that are actually in charge of actually supplying the medicines to the different pharmacies. So we have these establishments across all Senegal and including the rural zones and also the pharmacies from the pharmacies that are inside the country and also other pharmacies that are quite far off. And on the right, we have the public sector. So the supply for the industries, but we also have regional public structure. So we have the wholesales within the different regions that actually supply to all the different health systems, or in order to ensure that the entire health pyramid is covered down up. And some medicines like insulin that has actually benefit from subventions from the Senegalese state. Senegal just changed the statutes that allow us to carry out commercial operations and even take part in private companies. So all of these allows us to develop new approaches to ensure that medicines be available in good quality and in good quantity in the private sector, which is a challenge in itself. So here we have two sectors that actually do not cross out. From time to time, sometimes we can have the private sector that actually handle a few products that are not available. But we can see that on the left, with regards to private sector, we have the obligation to generate resources, the viability. On the right, we have structure that have the obligation of having the means in order for these treatments to arrive within these public structures in the countries where the resources are actually available. So, for the issue of public health, there are several points, and so we have these major points, and so we have some opportunities that come with transformations. So we have tax and legal framework, and also access to healthcare with public healthcare infrastructure that are being built everywhere. They are actually built with a high level of technical expertise, and also the universal health coverage actually ensure that the entire population have access to essential medicines. But the opportunities are also presented through the different digital markets with regards to quality and the tracing of good medicines, and also the digitalization of patient journeys in the virtual sector that allows us to have access to medicines. So some examples in Senegal or between public private partnerships. They are not really public private partnerships. That's why I choose a small p. So they are guided in this context. For example, in the COVID-19, where we exchange medicines, where the private, where the public sector had some medicines like azithromycin, and so they took some measures for distribution in Senegal, and also the when it comes to the different alcohol-based gels, and also we have the approach and the prices in order for this to be accessible to the population. So insulin today is distributed exclusively by the public structure, which is the PMA, and so because the state has actually subvention this. And so this was actually, um, this has been questioned recently within the program, and also the practice, and also for the distribution of contraceptives, and also for the vaccines, and also these are actions that we can consider as being some a part of a partnership, but not really a real public-private partnership. So if you take a look at the impact on health indicators and how we can follow up with the results through the improvement of the indicators of the maternal health when it comes to preventing infant mortality as well as other risks. So the major PPPs globally that have an impact on the health of populations, some have been displayed here. So we have the Holdback Malaria Program, Rollback Malaria Program, which is carried out in a lot of countries in Africa. We also have the vaccines. We have partnership with Gavi that allows us to see the availability of vaccines to where they aren't, and also this allows us to measure the efficiency and also to measure the prevalence rate and also the evolution of the mortality or morbidity rate. And so these actions have measure the impact on the health of our populations. So I drew inspiration from different documents that would allow you to delve deeper with regards to public-private partnerships. So you have these books, public-private partnerships globally for health. So you have the National Plan for Social and Health Development 2019 to 2028, and also the status of health, political economy of health. So thank you for your attention, and I'm available for any questions you may have. Thank you. Thank you, Dr. Kébé, for this detailed presentation when it comes to the definitions of public-private partnerships with regards to your activity in Senegal. So I'll give the floor to Dr. Barton. to present the
Dr.
results
Martin, vous la
of the
parole.
study. Mr. Martin, the floor is yours.
Arnaud, tu peux partager l'écran?
Can you please share the screen, Arnold?
Arnaud, tu peux partager la présentation, s'il te plaît?
La présentation est en cours de partage.
We are actually sharing your presentation.
Hello, everyone. Before to start my presentation,
Bonjour tout le monde. Avant de commencer ma présentation, je voudrais remercier mes co-panélistes, Dr. Yadav et Dr. Jules Kébé. Donc, c'est un honneur et un plaisir pour nous de vous présenter les résultats de notre étude des benchmarks sur la chaîne d'approvisionnement en santé publique en Afrique menée par VillageReach en collaboration avec l'ADPA. La question que vous pouvez vous poser est que pourquoi avons-nous mené cette étude de benchmarking? Au sein de VillageReach, nous travaillons depuis plusieurs années sur l'amélioration et l'accroissement de la distribution dans notre pays avec un focus d'observation que nous avons fait auprès des patients et que les gouvernements et les donateurs ne parlent pas assez de ces sujets importants et qu'il y a encore très peu d'informations sur cette question aujourd'hui. Nous croyons que cette information est vraiment capitale pour vraiment développer des politiques auprès de prendre des décisions et des donateurs et des gouvernements. Après le discours pédagogique du professeur Prashant, que voudrions-nous vraiment dire par ça? Professeur Yadav nous a donné un aperçu excellent sur le concept des distributeurs, parce que beaucoup d'entre vous connaîtraient certainement ce que c'est un distributeur ou bien un fournisseur. Mais
Next, please.
prochaine diapo, s'il vous plaît. Mais maintenant, nous allons parler de notre approche ainsi que nos limitations. Donc, l'étude a été conçue pour collecter assez d'informations pour comprendre les contraintes en Afrique par rapport à l'intégration des distributeurs privés dans la chaîne d'approvisionnement public. Nous avons suivi une approche pour vraiment utiliser les données. Et pourquoi y a-t-il des limitations à cette étude? Mais les résultats sont valides et nous pourrions utiliser cette étude pour vraiment commencer les plaidoyers. Prochaine diapo, s'il vous plaît.
Next, please. In terms of
En
scope,
termes
we had geography
de
also,
la champ,
our
les
geography
champs
is
d'application, c'est l'Afrique
the product scope focused
pour
on
l'application
pharmaceutical
ou bien
products.
des champs d'application de produits. Nous parlons des secteurs des pharmaceutiques ainsi que pour les produits sanitaires. Et
Next, please.
prochaine diapo.
Benchmarking topics and
Donc,
questions.
pour les sujets et les questions de benchmarking, donc, pourquoi
questions.
je ne vais pas
You
lire
can see that
chacune de ces questions,
Africa
mais
has 6
vous voyez que
questions.
nous n'avons
Each one
posé
to
que
know
6
engines
questions
and whether
pour
private
chaque
states can
pays,
legally
allant
supply the public health supply chain
par
on a
exemple,
regular
question
and
légale,
also on
oui,
a
que
recurring basis
si
versus
cela,
emergency
cette
basis.
distribution est faite de manière
For
récurrente.
countries where private
Et
distributors
pour les
supply
pays
on a
où il y
regulating
a
basis, we
plusieurs
can further on the
distributeurs qui
4 additional
distribuent
questions.
de manière récurrente, ils avons posé d'autres questions
Next.
là, en plus de ces questions.
So, according to the
Donc,
benchmarking,
selon les
what can be
benchmarking ou bien
the
cette
overall
étude de
state of
référence,
private
que
distributors
pourrait être
distribution
l'état
in
actuel des
Africa's public health
distributeurs
supply
privés
chains?
dans les chaînes d'approvisionnement africaines
We
des
learned
médicaments?
that less
Donc,
than 50% of
nous
countries
avons appris
accept
que moins de
recurring sales
50%
from private
des
distributors
sociétés
indicating
avaient
a
des
major
activités récurrentes
opportunity for improving
qui présentaient
access
une
to medicine
opportunité
in many
pour vraiment
countries
améliorer
in
l'accès aux
Africa.
médicaments dans beaucoup de pays africains.
What is holding
Qu'est-ce
back private
qui retient
distributors'
les
integration in
distributeurs
Africa's health
privés et
supply
leur
chains? It's a
intégration dans
question,
les chaînes
as
d'approvisionnement africaines?
Professor Yadav
Donc, professeur
said.
Yadav
Benchmarking
a
results
bien
show
expliqué les
4 countries,
résultats, ont démontré
including Tanzania,
4
Rwanda, Malawi, and the
pays, y
DSC,
compris la
use
Tanzanie, la
local
Malawi,
distributors
le
on
Rwanda
a
et les
regular
RDC
ongoing
qui
basis
utilisent
to supply the health
des
facilities,
distributeurs locaux,
while 5 other
alors que
countries use
5
local
autres
private
pays utilisaient
distributors to
des
supply the public
distributeurs
only
locaux
during a health
uniquement lorsqu'il y
emergency,
avait
as
des étages
Kébé had
d'urgence
said,
sanitaires, comme
or in
Dr.
the case
Kébé
of
l'a
or
si
in the
bien
case of
expliqué,
stockouts
ou bien
that
des
is
cas
evident that can be found
de rupture de
across the
stock.
Senegal, Mozambique,
Donc,
and
nous pouvons
Guinea
voir dans ce
and Burkina
cas, il y a
Faso.
le Sénégal,
And one
le
country,
Burkina Faso
Djibouti, did not
et il y a
use
un pays,
private
le
distributors
Djibouti,
to supply
qui
health
n'utilise pas les
facilities.
distributeurs pour vraiment fournir
In 4 countries with
médicaments.
regular
Donc, dans
supply
trois
by
de
private
ces quatre
distributors, in
euh,
France, the
sociétés,
legal
nous avons en
framework
France, nous
was
avons les
present,
cases légales.
indicating the
Donc, dans
importance
le
of
début,
this
nous
enablement.
avons surtout
In the DSC,
en
also
RDC,
a law exists to promote the participation of private distributors.
il y a
It lacks
surtout
clear enforcement measures, which limits the involvement in the public health supply chain. Next. Next slide, please. So for what products are governments involving private distributors? We asked for the product scope and found that essential medicines was the main type of products bought from local distributors. This is not only an indicator or distributor capabilities of many dedicated vertical supply health area. These are likely to become a necessity due to ongoing funding squeeze, like with the current
difficile par
situation
rapport
with
au problème de
US
financement, surtout
funding
comme ce que nous
cuts.
voyons venant de retrait des
Next,
sources de
please.
financement venant des États-Unis à travers des programmes comme le USAID.
So, what did we learn about distributors'
Donc,
ability
qu'avons-nous
to deliver
appris
the
par
public health
rapport à la
supplies?
capacité des
So,
distributeurs à vraiment
many
livrer
governments
ces
are
produits? Donc,
concerned about
beaucoup
whether
de
distributors
pays
have
sont
the footprint needed
concernés de
to
si
service the population
les
outside their lifestyle
distributeurs
cities.
disposent de la capacité de vraiment
Presence
fournir
across the
ces
continent is the key
services
issue. Low
d'une
delivery
qualité
costs and
optimale,
flexibility of
surtout en termes
supply,
de la flexibilité
both
et du
from
coût
the benchmark
de la
and
fourniture, que
our
ce soit
own
pour la
experience.
faire
We
référence
see that
et de
distributors
notre
who have the
expérience, nous
ability
voyons
and
que
are motivated to
les
set up
distributeurs disposent
operations
de la
when
capacité
they
et sont
have
motivés
long-term contracts
lorsqu'il
in
y a des
place.
contrats sur le long terme signés.
Next slide, please. So,
Donc,
engage with the benchmarking study.
avec
We
cette
hope
étude
that
de
you
référence,
found this
nous
presentation
espérons que
insightful
vous
and
avez trouvé
useful.
que
If
cette
you wish,
présentation
you can
est
use the results
vraiment
to
utile.
advocate
Nous
for greater
pourrions
involvement
profiter de ces
of
résultats
private
pour plaidoyer
actors
auprès
in
des
public health supply
gouvernements
chains
ainsi que
in line with
auprès des hôpitaux publics
the
pour vraiment améliorer les
H
chaînes d'approvisionnement,
in the line
surtout
with
selon les normes
health coverage,
de la couverture
universal
sanitaire.
health coverage, so that it's important now to engage
Normalement
with
indiqué par
with
l'OMS. Il est
private
important de
distributors.
vraiment
We also want to
s'engager
increase the
avec
number of
les
countries
distributeurs
joining
privés. Il
the
faut
study,
également
and
augmenter le
in
nombre de
this
pays
case,
qui
if you want to
participent
be an
dans cette étude.
informant
Et
for your
si vous
country,
voudriez
please
normalement
contact us.
être un
We
point
also
focal pour
share
votre
our
pays,
database
n'hésitez pas à
online
nous contacter.
as
Nous
a
allons
showcase
également
and
vous partager
interactive
ces documents en
benchmark.
ligne
If you are
pour que
interested
vous
in
puissiez
participate,
normalement
let us
avoir
know.
accès à ces documents. Donc, si vous voudriez bien suivre ou bien avoir accès à ces documents, n'hésitez pas à nous
Thank you
contacter
for your
pour
time,
ça.
attention,
Merci
and we
de
stay
votre
ready to
attention
respond to your
et
questions.
je serai
Merci.
ravi de répondre à vos questions. Pour une autre fois, merci.
Merci très cher Martin pour cette présentation concernant l'étude et concernant ses conclusions. J'invite tous les participants, si vous avez des questions
Thank you,
sur ce
Martin,
webinaire, à les
for
poser dans
this
le
presentation. I'd like to invite all the participants, if you have any questions on the webinar, please ask them on the chat so that we can collect them and then ask the panelists. I'd like to thank the people that started this approach. Madam Ida Mkiyo, who asked this question. He asked Martin, is there an impact on these actors? Is there? Is there? Was there an impact for the countries that actually followed this universal health coverage? Was there an impact? I think Mr. Martins. Can I respond? Please respond. The question is addressed to you. So thank you for the question. You know, the universal health coverage, and that is what Africa is actually working towards. So we do not have countries today that can actually say that we've been able to reach the universal health coverage totally. It's a process. We think that in this process, we cannot actually leave the private distributors on the side. So we should be able to maximize this coverage in terms of health products. And so Dr. Kébé mentioned if we want the health products to be available across the health pyramid, we should actually get in touch with the local health actors that have the capacity, uh, operational capacity to deploy resources across the four corners of the country in order for the business to be attractive for them because they also want to do business. For the state provides the favorable legal framework for these activities to take place. Thank you, Martin. Mr. Kébé, would you have something to add? And even Mr. Dr. Prashant, would you have something to add, please? No, I think Martin summarized it very well between the partnership between public and private sector and the objectives, the common objectives. Of course, we have the state needs to get in touch with these. But the private sector can actually provide the capacities and also the performance that it has with regards to the utilization of resources. Thank you, Dr. Martin. Thank you for these responses. So we have a second question from Viral Wagani, who was asking a question to Dr. Kébé. what were major difficulties encountered when it comes to distribution of health products, especially when it comes to um, international suppliers? Who is the question for, please? To you, Dr. Kébé, please. Okay. The major difficulty, I think we've actually gone through all of this with the COVID crisis. We can see that the countries that produce were actually constrained to actually stay within their local market to be able to preserve the local population. With regards to the disease, it means that the countries that were counting on imports, like Senegal, that imports over 95% of what they consume, were totally dependent of the producers that were based very far away from African continent. It means that every crisis that are going to strike, that is going to hit on the logistic impact, is going to actually have an impact on the availability of medicines. So in countries like Senegal and other francophone countries where it is very weak, is to have a fragile system that can be could be actually weakened by the crisis, and so they will need to actually go around Africa, go to South Africa, so we have maritime routes with costs that increase, knowing that the price of medicines need to be homologated, they are harmonized, that they are regulated by African states. They are not regulated by African states, so it means that the private sector they develop in an environment that is extremely difficult to carry out its mission. But today, we can see that the states are actually promoting local production, and also the big major producers are actually implied in the construction and building distribution platforms in Africa, like Dr. Prashant spoke about this, and these platforms would allow us to improve the availability of medicines for the different populations. Thank you, Dr. Kébé. So, one last question, Cleman. She would like to know, how do countries of the sub-region think of actually drawing profits from these public-private partnerships? This is for all the different speakers. Thank you. Can I respond? The question is from Inkombo asking, how can the countries in sub-region actually think of actually benefiting from these public-private partnerships? Martin, I give you the floor. Thank you, Dr. Clemo Combo, for this question. It even goes beyond. It's Africa, Like Dr. Kébé said, you have the statistics of Senegal that are practically similar for countries that are in sub-Saharan Africa. So a lot of medicines are coming from very far. So we should encourage local production, and this production is done by the private sector, like the African Union in its agenda for 2063 to have autonomy, to have some level of sovereignty, pharmaceutical sovereignty, when it comes to local production. So it started with the vaccine, and so going to go with for the other products. But we think that parallelly to this industry, we should actually develop a strong distribution industry, because products are produced elsewhere. You should take them and bring them towards places where they are going to be consumed, and that the population actually demand this. So should develop the other element, which is distribution. So the country must capitalize on this public-private partnership, knowing that all of them are engaged to achieve the Sustainable Development Goals (SDGs), and among these objectives, we have the universal coverage, we have health, and so to do this, we should actually have the private sector and also the WHO actually advises us the low and middle income countries to actually build with the private sector to be able to reach its objectives. So it is that is why we carried out this study. So this is an advocacy to push the deciders and also the governments and also the Pan African organizations, Africa CDC, regional WHO offices to encourage states to actually build with local private sectors to address the issue of this availability across our different populations. That's what I'll add quickly. I was talking about the structural transformation across different countries, especially the Francophone countries, in terms of regulation. So you have the administrative direction. So you have Senegal. I've actually reached the maturity level 3. So they joined 5 other countries that are all Anglophone countries. So that is the first Francophone country, and this implies an obligation to ensure that the entire channel is actually mastered. So we have a mission that has got to do with the substandard or counterfeit medicines. So there's the obligation to actually carry out inspections on distributors and controlling the cold room or cold value chain. This is actually going to bring the quality of these medicines in the market higher. And so the states would need to also invest and also reinvest in technology and infrastructure to ensure that they actually respond to this and also respond to the best distribution standards. And so through this, it is clear that the private sector becomes a first actor. And if we have an offer of service for the public sector to be able to mutualize the resources that are not unlimited to reach results. So you have the results, you have the impact, and also you have the partnerships that can could be on the health system, and also the impact on the citizens in a way as to ensure that the population be in a better health to be able to face the development and the challenges linked to them. Thank you to all the participants. Thank you to the panelists for what they've done. We've come to the end of this webinar where unfortunately we went over by 15 minutes. Uh, First of all, I'd like to thank all the participants at this webinar for their presence and for their questions. The majority of these questions will be actually be sent to the speaker. So the responses, we will try to send the responses to your questions by email. And when the responses are sent back, we will send these responses back to you via email. So thank you, Martin, for the study. Thank you, Dr. Prashant, for the quality of the introduction. I also like to thank Dr. Jules Kébé for the information on Senegal and how important these are. We've come to the end of this webinar, and I'll invite all the members that would like to take part in the study to contact us. All these countries that are not on the study, please contact us in order to be able to help us enrich our database for this and have better baggage so that we can actually do the advocacy, because the objective is to be able to get in touch with the deciders and to talk about the necessity of public-private partnerships. So we are calling on all the different participants to participate in this study in order to actually build on these information. So we've now come to the end of this webinar. Thank you all, and I wish you an excellent afternoon. Thank you.